Hello everyone, Dr. Roger Quesada here from the American Hip Institute. I'll be presenting today one of our projects. It's called the Birmingham Hip Resurfacing Clinical and Radiographic Outcomes with a minimum 2-year follow, a navigation versus non-navigation comparison. Closure can be found on the website. Hip resurfacing is a promising option for active individuals with end-stage hip arthritis who wish to continue being active. It has been shown before great return to sport with this surgery. The integration of navigation technology in orthopedics, and especially in the arthroplasty world, offer a real-time assessment of the limb alignment and the component position, which might enhance precision and potentially improve the outcomes of these surgeries. The purpose of the study is to report clinical and radiographic outcomes of patients who underwent hip resurfacing with the use of navigation, and compare the results to patients who underwent hip resurfacing without the use of navigation, with a minimum 2-year follow-up. This is a retrospective study. We review data for patients who underwent hip resurfacing between 2010 and 2021. Patients were eligible, they had complete pre-op and post-op patient-reported outcomes, and had complete x-rays. Included patients were divided in 2 groups based on the use of navigation during surgery, and then were propensity matched in a 1-to-1 ratio based on age at surgery and body mass index. The percentage of patients who met the minimal clinical important difference for modified Harris and VAS was included in the analysis. To rate the accuracy of the component position, the defined safe zones by Lewinick and Callanan were used, as well as the relative acetabular inclination limit outlined by Liu and Gross. In order to get the different variables for the radiographic analysis, TraumaCAD was used. We include acetabular version, acetabular inclination, and leg-length discrepancy. 38 patients were included in each group. As you can see, there was no significant difference in any of the demographics or the surgical approach used during surgery. Significantly improved from pre-op to post-op values in all the metrics, and there was no significant difference in the post-op values between the 2 groups. Patients who underwent surgery without navigation had 10 patients outside of the Lewinick safe zone and 14 patients outside of the Callanan safe zone. When we compare that to the navigation group, 0 patients and 3 patients respectively were outside of these safe zones. You can see here on the left side, patients who underwent surgery with navigation were less likely to be outside of the safe zones compared to the right side. The blue dots indicate patients who underwent surgery without navigation. Similarly, when we compare to the rail system, patients who underwent surgery with navigation were more likely to meet this threshold. Specifically, patients who underwent surgery with navigation, only 2 patients were outside of the 99 confidence interval safe zone, compared to 10 patients in the non-navigation group. In terms of complications, 2 patients from the non-navigation group required further surgery. 1 patient underwent iliopsoas fracture lengthening due to iliopsoas tendonitis impingement because of the malposition of the cup, and 1 patient underwent thoracotopic calcification that required excision. Our study demonstrates significant improvements in the short-term outcomes of patients who underwent hip resurfacing. Importantly, the additional navigation during surgery optimized the accuracy of the acetabular component position, being more likely to be within the safe zones. This precision might be associated with a decreased risk of failure or revision surgery. However, longer studies are needed to fully validate this conclusion. Thank you for listening.